Okay. Can someone tell me, can you hear me? Alana, sound is all right?
We can hear you, Tony.
Okay. Good afternoon, everybody. My name is Tony Hawkridge, and I'm based at the National Immunisation Technical Advisory Group Support Hub, or NISH, at the University of Cape Town. And I'm here representing Professor Kagina, who would have loved to have been here, but he's currently in London and traveling, and he couldn't. So I'm going to be chairing this afternoon's session. I wanted to briefly just introduce the seminar, but before I do that, I think let me ask Salim just to walk you through what to do about the interpretation service. Okay, so it's not difficult, but Salim, can you just give very brief instructions? People who it is available in French, English, and Portuguese. And Salim, how do people access that?
Yes, I'm going to be speaking in English. So if you do only understand English and Portuguese, I'm not quite sure. But there is a little three dots at the bottom of Zoom. You will see three dots. And when you click the three dots, it goes to more. There's a little world icon underneath that says interpretation. If you just click on that, you will then be able to choose which channel you want to listen to the webinar in. We do have English, French, and Portuguese. That's it. Yeah.
Okay, and if you do have problems, we're going to ask you. I mean, you can use the chat, but we prefer you to use the Q&A facility in Zoom because it's just easier for us to follow it and to get it documented. So if you are running into problems, maybe you could pop a question in there, and Salim will respond to it. But also, as we go through the seminar, if questions come up which you want us to ask the panel members later, that's the place to put it, Q&A. If you are unable to type and you really have a good question, a burning question later, we will try and give opportunity for people to ask questions verbally, but we would prefer it if you could type them into the Q&A box in Zoom. All right, so I'm briefly going to just tell you why we felt it was important to have this webinar. And I think a lot of this would be known to you. You know that the EPI has been around for many years, since the early 70s, and measles has been part of the EPI for many years, but it still remains a leading cause of childhood mortality, not just in low and middle income countries, but increasingly around the world. But in LMICs, the process of increasing the coverage of measles vaccine, which is what you need because you need to get such a high coverage, has been hindered by a number of things. One of them is the high wastage of measles vaccine, and another is missed opportunities for vaccination. And one of the drivers of this missing of opportunities for vaccination is, and we know this from before, health workers' reluctance to open the standard 10-dose vials if they only have one person, one child presenting for vaccination, or maybe two, because they're worried about wasting. They're being frugal, they're being dutiful, they're being conserving of what resources they have because they've got such meager resources they don't want to waste, and so the children go unvaccinated. And to try and address this, a number of countries, Gavi eligible countries, have for some years been exploring whether they should switch from the 10-dose vial to a 5-dose vial presentation. And so what this webinar, what we're trying to do in this webinar is to present the findings, the synthesized findings from a number of impact assessments which have been performed around this switch. One is from Zambia, and another was from Ethiopia. And we've got colleagues that I'll introduce to you shortly from both of those countries. But this session will basically explore the synthesized evidence in context, including the trade-offs between vaccine wastage on the one side, coverage rates, cost effectiveness, operational feasibility, and then obviously the implications for those who are footing the bill, the funders, the countries, the immunization implementation support organizations. So that's what we're going to be trying to do in this 1.5 hours. And just to briefly introduce, we're very lucky to have some top presenters with us. So we've got 5 panelists, and I'll just quickly introduce them. We've got Mulugeta Tamire from Ethiopia. I'll tell you a bit more about him. We've got Mumbi Chola from Zambia. We've got Elizabeth Odowole from VACFA, my unit here in UCT. We've got Balcha Mazresha from the WHO AFRA. And we've got Amina Boatmani from the Gavi office in Africa as well, I think, Amina. So those are our 5 panelists. And we've got 3 moderators. I'm one of them. And we've got Maggie Archbold from Linksbridge, all the way in Seattle, very early there. And we've got Gulam Kandaka from NSERS in Australia. So it's very late in the day there, very early in Seattle, and sort of midday-ish around about here. So just to briefly tell you about the panelists, Professor Tamire is from Addis Ababa University, and he's also serving on the Ethiopian NITAG. He's a specialist in preventive medicine and public health. Dr. Chola from Zambia, he's also a member of the Zambian NITAG, and his expertise is in health policy, reproductive health, and infectious diseases. Dr. Odowole from Nish here in Cape Town. She's particularly expert in vaccine implementation science and evidence-informed decision-making. And then Dr. Mazresha, many of you probably know, he's from the WHO regional office. He's got expertise in immunization systems and vaccine preventable diseases more generally. Amina from Gavi, she's the program manager for measles and rubella vaccine program for Gavi. And then the moderators, I've introduced myself. Maggie is from Linksbridge in Seattle, and her work there focuses on expanding the capacity of immunization programs and supporting NITAGs through coordinated technical assistance. And then lastly, Prof. Gulam is the Associate Director for Global Health at NSERS. He's a public health physician with 2 decades of experience. So I hope you appreciate we've got a really good panel, and I'm going to hand over directly now to Prof. Gulam to introduce the Zambian study. So over to you, Gulam.
Thank you, Tony. Good afternoon, evening, everyone. It's a pleasure to be joining you all today. So now I would like to invite Dr. Musaku Monchanea Mumbi from the University of Zambia to provide a high-level overview of the Zambia study findings. Thank you.
Thank you very much, Gulam, and thank you for the opportunity to share some of our lessons from this study that we did in Zambia. So this is essentially, I'm sharing this on behalf of the team from Zambia, where we're looking at the impact of the switch that was done a few years back, and then want to share our experiences as well as issues around cost effectiveness and the lessons we learned from the findings. So just a little background. The EPI program was introduced around 1975, and measles was one of the first 6 vaccines that was introduced at the time. And since then, we introduced the second dose of measles in 2013, and then we switched to MR vaccines in 2016. And then the following year in 2017, there was a phased introduction of measles rubella vaccines into our routine immunization program. And then in 2022, there was a dose presentation switch where we switched from measles rubella 10 to 5-dose containing vials. And this was guided by findings from a study that was done around 2017, 2018, which showed that there was benefits in introducing a 5-dose vaccine, and there wasn't major differences in terms of cost effectiveness compared to the measles 10 containing vials, but there were positives as far as health worker attitude towards opening the vials, as well as an overall impact on the coverage of measles vaccination based on the findings from that study. Next slide. So for the findings that we're sharing for this study, the overall objective was to conduct a comprehensive impact assessment of the switch that was conducted in 2022. And specifically, we sought to measure the impact of the switch on MCV1 and MCV2 coverage at national and subnational levels. We sought to evaluate the impact of the switch on healthcare workers as well as caregivers' perceptions and behaviors, and to also try and obtain retrospective implementation data around practicalities, the costs, equity, as well as cost evaluations that are important for the effectiveness of the switch from the 10-dose to the 5-dose vial. The fourth was to try and document the lessons that we learned, as well as identify some short, medium, and long-term benefits of leveraging local academia to support evidence compilation to aid national immunization technical advisory groups, in this case, the Zambia NITAG, for their decision-making as far as driving policy for our immunization program. Next slide. So a summary description of our survey and the design. So this was a mixed method study. We had both qualitative and quantitative data that was collected. It was cross-sectional, meaning we can only infer based on the time point in which the data was collected. This was done at health facility level, and we targeted specifically facilities that offer measles vaccination. Our respondents included caregivers of children who are deemed eligible for vaccination, as well as caregivers who administer these vaccines in these health facilities. We used structured questionnaires for our quantitative data, while interview guides were used to collect our qualitative data. And this was done via face-to-face interviews. And the map on the right shows the provinces where we covered, which were covered in the study. We had Wapula Province, Copperbelt Central, and Lusaka Province. And the selection of these was based on performance of these provinces as far as performance in terms of coverage of measles 2 vaccine. Next slide. So I'll just run through some key findings based on the objectives. So like we said, our first objective was to measure the impact of the switch from the 10-dose to the 5-dose vial on MCV1 and MCV2 coverage at national and subnational levels. Next slide. So the two graphs on the left, the one on the top, the first figure presents results from the national level, MCV1, and the one below it on the left down here is the MCV2 national median coverage. So as you can see, from 2018, we were at about slightly under 90% at 89.4, and there was a drop to about 79.4% coverage in 2022, which stagnated a little bit, but then rose after 2023, and we currently stand at 86.7, whereas the subnational coverage, or rather coverage for measles MCV2 down here was slightly lower and remains consistently lower than the MCV1 coverage. On the right, we have subnational data, and this is largely at provincial level. And we had a similar trajectory at national in terms of MCV1 with a drop over time from 2018 to 2022. And it has been slowly rising since then to about 84.2 currently. And then for MCV2, it still remains below the coverage for MCV1, and we currently stand at about 64%, but similar trend over time with a drop in 2022 from the 65.2 we had in 2018. And then, we had that drop, and which coincided with around the time of COVID. And it was around that time that the switch was implemented, just at the tail end of the COVID epidemic. Next slide, please. Next slide. So to summarize some of the key findings, although I must mention that this is, as was mentioned, a high-level summary, we saw that MCV1 coverage was consistently higher than MCV2 at both national and subnational levels. And MCV2 was substantially lower overall, although there have been some improvements both at national and subnational levels. The median MCV coverage nationally declined by about 4 percentage points, while MCV2 declined by about 2.7 percentage points. At subnational levels, the declines in the median coverage were also observed across several districts for both MCV1 and MCV2. We did look at timeliness of vaccination. So in this instance, we were looking at the number of children that are vaccinated based on the immunization schedule. And we found that the timing was broadly consistent across geographic areas. But one thing we noted was that about 62.1% of children were vaccinated on time for MCV1, whereas there was a lot of delay in administration of or timing for vaccination as far as MCV2 was concerned, with over 90% having been vaccinated beyond the recommended age as per immunization schedule. And this remained consistent across all subgroups and subpopulations, which suggests a widespread systemic issue with regard to delivery or timely delivery of the second dose of measles. Next slide. The second objective was to try and see if there was any impact of the switch on healthcare workers and caregivers' perceptions and behaviors. And next slide. What we found was that among caregivers, there was limited information on the switch from the 10-dose to the 5-dose vial. So there was no campaign that was conducted in the switch where communities were sensitized that there was a change in the vial presentation. And caregivers also did report issues around vaccine hesitancy, which was pretty much common across the different sites. They did, however, recognize that well-communicated community outreach by healthcare workers was perceived as a facilitator for vaccination. So in areas where there was a good rapport between the health facilities and the outreach activities that they conduct within the communities, there was a feeling that this encouraged caregivers to take their children for vaccination. One challenge was that competing responsibilities like economic generating activities such as farming or other income generating activities that caregivers engage in, and not having someone to bring the children on their behalf or accompany them was considered a barrier towards vaccination. So this, I think, even with regard to MCV2, this came out as one of the major challenges in terms of bringing their children to be vaccinated on time. But however, they did report that they experienced reduced waiting times and reduced repeat visits, as well as improved trust, since they noticed that there was this change in since the switch was implemented. As far as healthcare workers are concerned, before the switch, healthcare workers were a bit hesitant and feared wasting doses. So they would wait until they had a large number or sufficient numbers of caregivers and children before they vaccinated. And this was despite the instruction that they should open irrespective of the number of children that are available to vaccinate. And they did note that there was no considerable change in preparation, reconstitution, or maintaining the cold chain with the change in the dose presentation. But they did mention that there was poor communication on the switch. There was poor communication, and there was no infographics, for example, job aids and such that were provided at the time of the switch. There was also little or no time given to process the change before they had to start using the switch. And they did, however, receive the switch with enthusiasm, and they were happy that they had the 5-dose containing vials which they could open as and when they had, irrespective of the number of children that they had who had come to vaccinate. Next slide.
Dr. Mumbi, we're a bit pressed for time. Can you wrap up soon?
Yes. So next slide. This was around the cost effectiveness, and we found that before the switch, it was around $25 to vaccinate per child, and this dropped after the switch in 2022 to about $19, representing a $6 reduction, or 24%. We also had reduced cost in dose handling, or cost per dose handled, from about $628 to $378. And the incremental cost for each additional child vaccinated was about $5.6. In terms of equity, there was the largest absolute increase in doses administered was in rural areas. And also there was increased wastage, about 20% in those areas, while the largest increase in absolute doses administered in urban areas also increased, and the costs were higher. The cost per child vaccinated were higher in rural areas compared to urban areas. Next slide. So to conclude, we did see some clear benefits with the change in dose presentation, although coverage challenges still remain, as shown in our national and subnational data. Vaccine timeliness is also a concern as it relates to child protection and herd immunity. And we also saw greater confidence among healthcare workers in terms of opening the vials and vaccinating children on demand. And we also learned that there's need to have strong governance support in implementing the rollout or the switch with partner support, and we need to ensure that there's supervision as well as improved supply chain systems. So we need to pair these switches with sensitization and supervision. We need to strengthen monitoring using routine data, in addition to other data sources such as surveys. And overall, the 5-dose switch offers an opportunity to close immunity gaps, improve service delivery, and support measles elimination in Zambia and similar settings. Next slide. Yeah, I think that ends my presentation. Thank you.
Thanks very much, Dr. Mumbi. Professor Gulam, any comments from you, or should we just hand over to Maggie?
Thank you. Please go to the next speaker.
Okay. Over to you, Maggie.
Thank you, Mumbi. And it's my pleasure to introduce Professor Mulugeta. Professor Mulugeta is the Dean of Public Health at Addis Ababa University. He's been directing this study in the country and will take us through the findings. I want to recognize him in addition to being a leading researcher, student mentor, and committed public health practitioner. Dr. Mulugeta has been exceptionally flexible and diligent over the course of this project with his team. It's important to note that Ethiopia was still using 10-dose vials nationally for routine immunization when this research project began. And the country started transitioning to 5-dose vials in selected districts around late September, early October last year, based on depletion of remaining 10-dose stock. So I really want to appreciate Dr. Mulugeta and his team at Addis Ababa University for the truly impressive amount of work that they undertook to collect a vast amount of valuable research over a relatively short amount of time. And look forward to hearing his findings. Over to you, Professor Mulugeta.
Thank you, Maggie, for the nice introduction. Can you hear me? Hello?
We can hear you.
We can hear you.
Yeah, okay. So as the time was 5 minutes, I directly go to the key findings only, not the details. And we conducted mixed method research using quasi-experimental method for the quantitative and also descriptive qualitative research. In fact, costing was also considered. We, as Maggie clearly mentioned, the switch it was planned to be in August, but happened in late September and early October. So we aim to have like intervention and control groups, and for that baseline data, since the switch was started after we initiated the study, we traced 3 months back data from the health facilities, and those data was including from April, June, and July. We skipped May because there was a big catch-up throughout the country. And we included, we considered both MCV1 and MCV2. And the MCV1 data was collected both from facility and also households. The households data included 896 participants for MCV1 and 948 participants for the MCV2. So when I go to the objectives and the findings under each objectives, the first objective for the quantitative part was assessing the impact of switching from 10-dose to 5-dose. Then we had findings from facilities as well as also household levels. The facilities were around 228. By the way, we recruited the districts, 5 districts from 10 districts from 5 different regions as intervention group, and also 10 districts from the same regions, considering the urban, semi-urban, rural, or agrarian, as well as some pastoral settings. So these findings are from those 5 regions, not from the whole countries. So the whole country. So Addis Ababa, Central Ethiopia, Oromia, Somali, and Gambella were included. So MCV and C stands for intervention and control group. So for us, control groups are the groups which didn't, or the facilities which didn't switch from 10-dose to 5-dose. And because of our close collaboration with the Ministry of Health, they recruited, based on our recruiting criteria, we collaboratively recruited the districts, and the switch happened in the selected facilities, districts only. That's why we have intervention in the control group. MCV1, the coverage increased from 84 to 92 at facility level, 75 to 93% at household level. In the control setting, from 71 to 76 at facility level, and 73 to 76 at household level. And also intervention group MCV2 from 81 to 89, whereas intervention group at household level was from 66 to 92. And in the control group, MCV2 increased from 82% to decreased from 82 to 80%, 2 percentile point decrease, whereas MCV2 increased at control setting based on the household data. There was a slight increase. So the other findings that we found were timely vaccination of MCV1. That means exactly in the 9th month, it rose from 58 to 73 in the intervention group, and also from 55 to 63 in the control group. So you can see the percentage change was higher in the intervention group. Delayed vaccination declined by 13 percentile point in the intervention group, but only 2.2 percentile point in the control setting. Then routine service delivery became more flexible, as it was clearly indicated in the introductory session of this webinar, because the care providers were hesitant to open when there were a small number of children, but that was addressed by the switch, and then it brought flexible schedule as well, because previously it was appointed once in a week, or sometimes in some remote areas once in 2 weeks, and in Addis, in some facilities it was like twice in a week, but that was totally changed, and most of the facilities started providing MCV vaccination daily base. That was one of the reasons for the flexibility. When we see the qualitative findings for the second objectives of perception of health workers as well as caregivers, awareness was inconsistent and informal, both among healthcare providers as well as community members or caregivers. Some of the mothers knew that there was a change when they arrived for the vaccination, and the training provided for the health facilities was a bit fragmented and delayed, and waiting time. But the positive things were waiting time for caregivers and the children was reduced, and health workers reported high satisfaction and a relief, because before, when 3 mothers were available or waiting with 3 kids, then they could not open because they wanted to reduce the wastage. So that was somewhat for them a source of dissatisfaction, looking at the mother traveling long distance and returning home without vaccination was some sort of dissatisfaction for them. As clearly indicated before, missed opportunity for vaccination decreased as facilities could open a 5-dose vial even for a small number of children. And also switch improved operational efficiency as well as reduced providers' hesitation to open a vial. The third and the less addressed one, the costing part, as this was a prospective type of study, and the study period completed when we made maximum of 10 weeks or more, not more than 8 weeks on average. We couldn't clearly address the costing part, but we saw that in intervention districts, vaccination wastage decreased after the switch, while increased in the control districts where they were using 10 doses. The switch is marginally cost effective. That means achieving increase in coverage and also reduction in vaccine wastage, while significantly decreasing the financial burden on households and also improving operational efficiency. As we said, when the mothers return and they come back again, that caused external or additional cost for them. But when they find the service on one round, that could directly decrease the cost. The combined picture in the substantial household saving and property coverage gains were achieved at modest additional facility costs, and the findings rely on only very short-term duration or 2 months data. Long-term effects of switch cost switch and the cost effectiveness and equity remained unexamined. When we conclude, switching from 10 dose to 5 dose led to large, significant coverage gains, even though there could be some other confounders, accelerated timely vaccination while reducing delayed dosing, which can demonstrate a high impact optimization for low volume settings. Inconsistent awareness and also delayed training, but we found that in qualitative, but reduced waiting time and missed opportunity were somewhat positive things. This could pair Vials switch with structured training and clear communication, or demands high-level awareness creation among caregivers. Intervention reduce wastage and the household costs, but long-term equity and the cost effects unexamined due to short follow-up, which needs further study to, by the even in terms of coverage, we don't know if there could be some change in coverage because of seasonal or issues like in relation to rain, in relation to farming or harvesting activities. Given the evidence from this limited data over a short time, we recommend scaling up the switch, prioritizing low volume facilities while addressing gaps in training, community awareness, and also considering country-specific context, including climate change or internal conflicts and other things which could hinder the implementation of the switch. And also, in fact, preparation of cold chain in advance to address the increase in volume due to the switch is also very mandatory. Thank you for your attention. I don't know whether I kept the time or not. Over to you, Maggie.
Thanks very much, Prof. Maggie, any concluding remarks?
Really great presentation. And as Professor Mulugeta mentioned, the increase in session frequency is really notable, even given the short amount of time that this intervention has been in effect. And myself and some colleagues at NISH were lucky enough to visit Professor Mulugeta and his students at Addis Ababa University in December last year. And we visited some health facilities and saw that in practice for health workers that previously were holding vaccination sessions once, twice, or 3 times a week, and only in the mornings typically, we're now shifting to daily vaccination sessions, opening vials throughout the day. And caregivers who had previously experienced really long wait times and being turned away after waiting a long time noted that those experiences were significantly improved. So even though this is a short amount of time to assess the intervention, I think these types of process indicators signal the strong impact potential that this switch could have. And I have follow-up questions, but I know we have a Q&A discussion, so I'll hold them and turn them over to you, Anthony.
Back to me, yeah. Thanks very much, Maggie and Prof. So you've got the 2 case studies now, the results, and we're going to change course a little bit. And I'm going to hand over to Dr. Elizabeth Oduwale, who I introduced earlier. She's a qualitative PhD researcher at NISH. And she was involved in both of the studies, and she spent some time speaking to some of the key role players, particularly the NITAGs, and particularly the academics who were involved there, and the interplay between those 2 and the EPI. So she's going to strictly 5 minutes, please, Elizabeth, to tell us what she found. Thanks, Elizabeth. Dr. Elizabeth.
Oh, don't do this to me, Tony. Thank you so much. Can you see my screen, and is it in the right?
We can, yes, thank you.
All right, great. So thank you so much. So like Tony mentioned, I did walk across both countries interviewing key stakeholders. And in the next couple of minutes, I hope to run through very text-dense slides because it's a qualitative study, and share with you the findings my findings from those interviews and literature reviews. All right, so just a second. We all know that national vaccine optimization decisions depends not only on implementation capacity, but also on whether countries have sustainable ways to access, interpret, and apply local evidence. Moreover, the ever-expanding work of NITAGs to provide timely, evidence-based recommendations to their Ministry of Health on vaccine introduction, life course vaccination, response to emerging pathogens, all require that they be capacitated and strengthened. And that is where NICH stands. So with this landscape analysis, we at NICH present a critical gap that had been identified, which is the lack of structured linkage between evidence producers, as you can see on your slide, the definition of NITAGs, and evidence users. The evidence producers are actually the academic institutions, and the evidence users, the NITAGs. And you can see that NICH is correctly situated as a bridge between the two, being an academic institution-based initiative. So what did I do? Conducted a landscape analysis in two parts. The first part was a literature review of, relevant records that were found. Globally, a total of 154 records were identified, and only 11 made it through our selection criteria. The second part, which I will go into more details, entails the key informants interview. A total of 18 key informants interviews were conducted by myself with 7 NITAG members, 9 academic from both countries, and participants from country immunization partners organization, in this case, WHO and UNICEF. So I'll just run through the findings and discussion. The first one is that the literature review tells us that globally, literature's documenting linkage between NITAGs and academic institution is very, very limited. And so a lot needs to be done in this area. And then of the of the key informants interview, I'm just going to discuss 8 main themes quickly that were identified. The most important one being the informal nature of the NITAGs and academic institution linkage. Yes, there is a linkage between them, which my participants mostly described as a working relationship, but is fraught with challenges, even though it has its benefits. And I'm aware you will be getting the slides later on, so I will not be reading the quotes, but you could see that my participants, really made a case that to what they think, in their opinion, will be the best to optimize this critical linkage is to formalize it, by having MOUs, that is the Memorandum of Understanding, and or terms of references between the NITAG as a decision-making or a recommendation-making body in the government and academic institutions. And then when I asked them, what institutions would you prefer to be linked with? On the average, from both study countries, they said the oldest and the most equipped university is a must, and then also regional academic institutions are also to be included so that they can generate the much needed local data. And when I asked them, how would you want to see this relationship, formalized or linked? It was a mixed bag, and it's contextual. Some prefer the bottom up, that is, you start with the individuals, and then through the department or schools, up to the vice chancellor, and others recommend start from the top if you want to get this done, and then it can filter down, to the along the structures. Start from the top, from the vice chancellors, the deans, and then it can filter down. And when I also asked them, the MCV dose per container vial switch, did your NITAG make a recommendation? Both countries said yes, and that the recommendation, it was a good thing. And as you can see from the presentation of both countries, it is good. And I asked also, did they get assistance from country immunization partners? And participants from both study countries said yes, they did. And they made a point to reassure me that the country immunization partners were very, very useful, providing them with data, helping them to interpret where applicable, but they did not influence the recommendations. And they also, were eager to talk about other challenges that assailed their operation. And I think I just have two on the slide here that I want to highlight. The one is the global issue of money. Funding was identified, limited funding for day-to-day NITAG running, and of course, the challenge also of limited access to expertise, especially health economics seems to be a scarce skill. Both countries identified that. And yeah, so as I conclude, trying to please my colleague Tony, the findings from the literature review corroborates my findings from the key informants interview. Both the literature review and the key informant interview identified the lack of documented formalized relationship between NITAGs and academic institutions, and the ad hoc nature of the informal relationship that currently exists, the need, the importance, and the advantages of formalizing the relationship between the two entities. I need to flag here that even though the WHO establishing guidance establishing NITAGs does not explicitly require a formalization of the linkage, and even European NITAGs and other NITAGs in the global north largely lack a formalized partnership. But the NITAGs in LMICs, where most of us are situated, must be agile, and we must be adaptive in our peculiar context, especially in the light of shrinking global funding support. And we should explore adopting and adapting a niche-like model. That is an initiative that sits in an academic institution and can bridge or be the bridge between the evidence producers and the evidence users. So with this, I've come to the end of my presentation, and thank you all. Tony, back to you. How did I do on time?
Thank you very much, Elizabeth, Dr. Elizabeth. Yeah, it's always nice to, I think it was a timely reminder that, behind any policy decision, there's always parties that are involved that you don't always see. So there's the WHO, there's the NPI, there's the NITAG, there's academics, there's communities, and so on. And how do those things fit together? And it's not stuff that you can easily reduce to a 2x2 table and work out, relative risk. I think, the qualitative research brings out a lot of richness there. So thank you for that reminder. Thanks, Elizabeth. All right, I want to keep the last half hour for Q&A. And just a reminder, please, if you maybe joined late, if you do have questions for the panelists, please pop them in the Q&A facility in Zoom. I can see that there's a couple there that we've already collected, and we're going to come back and start addressing them just now. But maybe for the next 10 minutes, you've still got a chance to pop some in there, and that'll just make the conversation richer. But before we get to that, we've got two people who I did introduce. One is Balcha Mazresha, who's from the WHO office in Africa. I think he's based in Harare. And the other is Amina Butmani, who's from Gavi. And we've asked them just to reflect on these results from these two studies and contextualize them with respect to, in Gavi's instance, the support given to countries and partners to accelerate measles control and elimination. So how does it fit in with the big picture for them? And for Balcha's perspective, from the WHO perspective, how do these results fit in with respect to other strategies which WHO is also engaged in to try and accelerate measles control? So let me go to Amina first. Over to you, Amina.
Thanks, Tony, and thanks really for the study team at VACPA UCT-ish, and thanks to the presenters from also the study project in Zambia and Ethiopia. So as Anthony said, I'll really try to make a link with the study findings and how it relates to Gavi and broader Gavi supports funding and policy considerations as we move into Gavi 6.0 as a new strategic period, but also broader support that Gavi provides with respect to the measles and rubella program. I'll try to keep it brief so that we keep it to time. So I'll not be presenting slides, so I'll be just sharing some comments from my side. So clearly, we very much appreciate all the work and effort put in the study. In terms of the findings, we believe it really provides strong evidence from real-world rollout of the switch in both Zambia and Ethiopia, being two Gavi-supported countries for their programs. And obviously, within a broader context, these are very much consistent and aligned with a broader and growing body of evidence with regards to the MCV 5-dose switch, both in terms of the evidence generation, but also in terms of the return on the country experiences. So we are seeing more and more countries interested in considering the switch, making the decision to switch, either implemented or have assessed the impact of the switch. And this clearly demonstrates the impact that it has in terms of the improved service delivery and responsiveness of the system, as well as the impact with regards to the reduced missed opportunities for vaccination. We must recognize there is a growing global momentum around portfolio optimization, more particularly around the MCV 5-dose switch within the context of this conversation, and we're seeing an increasing number of Gavi countries adopting the 5-dose vials as their portfolio, option for the measles or measles rubella vaccine. And there is obviously a large potential for expanding and increasing the coverage for MCV, and particularly addressing some equity issues with regards to reaching zero-dose children. This is obviously aligned with the Gavi priorities in terms of increasing coverage, reducing the missed opportunities for vaccination, and equity, as I said, in terms of reducing the numbers of zero-dose children. It also fits within broader routine immunization strengthening interventions, including addressing the MCV2 dropouts and stronger coverage at the second year of life, but also really addressing and improving efficiency with the context of a constrained resources that countries might be facing. It's also worth noting that the switch in itself is not just a product change, but really is a service delivery optimization within a broader system change. It does not execute, on its own, and it does not bring up the the impact that is anticipated on its own, but really requires adequate planning and to ensure successful implementation. It all starts with really ensuring there's an evidence base for the decision and the budgeting considerations, requiring vaccine prioritization and optimization exercises, and also NITAG reviews and decisions. It also requires strengthened healthcare worker training and supervision, engagement with communities, and ensuring effective communication to address a certain hesitancy and to improve uptake, but also adequate and careful planning in terms of the stock management and supply planning, and also ensuring cold chain readiness. There are also considerations in terms of data systems to monitor the coverage increases expected, the wastage, and the reach of the vaccine, but also continuing investments in terms of the outreach modalities as well. In terms of the policy and funding considerations as we move into Gavi 6.0 and where the switch for MCV 5-dose fits into that, just to say that it's one of the many trade-offs and decisions for prioritization and optimizations that are becoming increasingly important for countries to make. And an MCV 5-dose switch is clearly a key optimization lever within the routine immunization that countries can consider for their portfolio. But just to say and to emphasize that it's only complementary and is not transformative on its own, but really is part of a bigger myriad of broader routine immunization strengthening efforts. So in Gavi 6.0, in terms of the financing implications moving forward, both measles and measles rubella vaccine programs are still a priority for Gavi. They are guaranteed under the vaccine budgets for countries that are eligible for support. So countries can obviously opt to implement the switch to 5-dose. The switch is no longer a standalone request for a grant in its own, but it's really embedded within a single funding envelope that requires those prioritization decisions. In terms of the vaccine procurement costs, they are covered on the vaccine budgets, and the operational costs to cover trainings, logistics, the implementation support are needed to be prioritized from each country's cash budgets. Just to mention, and before I move to the bigger overall picture of the MR program support, it's clearly a shift that the MCV 5-dose brings from really considering optimizing the programs while introducing a new vaccine, but really looking at how to deliver the same existing vaccine more effectively and what gains can that procure in terms of optimizing the delivery versus expanding or adding new vaccines to the portfolio. Really just to say that this comes on top of many other types of support that Gavi provides in the context of measles and measles rubella support, which, as I said, remains a strategic priority and is a central goal in terms of the global immunization. We recognize also that the routine immunization system might be facing increased strain, and there might be immunity gaps and increased risk of outbreaks. And that's why the approach for measles and rubella focuses on both strengthening the routine immunization as a foundation with the possibility of a switch to a lower dose vial, but also consistently supporting and optimizing time-sensitive preventive campaign to close immunity gaps for measles and measles rubella. So the continued support for the routine is also complemented with rubella vaccine introductions in some countries in some WHO, African and EMRO region that are yet to introduce the rubella-containing vaccine. For now, they're only on measles monovalent, so that's one of the key types of support. And the other one, as I said, is really on the preventive campaigns, the follow-up SIAs, where Gavi continues to support children targeted by those SIAs. And these are guaranteed and protected. Operational costs are also included in the country budgets. There's also a new kind of reimagined way of looking at campaigns so that they're not just delivery platform, but really identifying opportunities to reach zero-dose children and looking at opportunities to strengthen the routine system and integrate it with other health interventions. And then, of course, there is the Outbreak Response Fund that Gavi supports through the Measles Outbreak Response Fund. But just to also mention that there's also funding of technical assistance that country could prioritize to support measles and rubella program, but also broader immunization needs, as well as diagnostic support, because Gavi is also supporting measles, IgM, rapid diagnostics tests, and countries could access also that support looking at Gavi 6.0 program funding guidelines. Just to conclude, just some key takeaways in terms of Gavi support. The switch is a central element in terms of the Gavi 6.0 vaccine prioritization and optimization options. There's continued financial support in terms of the vaccine, the measles and rubella vaccine program, with much more structured and protected funding mechanisms. And there is a much stronger focus on effectiveness, integration, sustainability, and impact. I'll stop here. Hopefully I didn't get over too much. Thanks, Anthony.
Thank you very much. I mean, it was very comprehensive, and I'm sure we'll come back to some of those points. Dr. Balcha, from WHO's side, do you want to just reflect on the two studies and contextualize them in terms of your other strategies for measles?
Yes, thank you so much, Anthony. Good afternoon, good morning, colleagues. So most of the points I would have emphasized upon have been mentioned by the different speakers. Particularly, Amina has gone into length into some of the points, but I'll try to just draw some thoughts that we can use for discussion. So the findings from the Ethiopia and the Zambia study, basically in terms of improved health worker readiness to open vials, in terms of more frequent sessions having been implemented, better, relatively improved coverage documented within the limitations of both studies and the durations that the studies were implemented without incurring significant wastage. These are basically the impacts that we're looking for as we introduce 5-dose vials and switch from 10-dose vials to 5-dose vials. However, as Amina said, this does not happen in a vacuum. And we have more or less documented similar kind of qualitative responses from 7-8 countries where we have implemented the switch to 5-dose over the past 4 or 5 years. But this is the first time, I think, in Zambia and Ethiopia, where we've managed to document some quantitative results with regards to improved coverage, as well as relatively lower wastage rates, or at least without incurring higher wastage rates, which is great. But again, this does not happen in a vacuum. And I'd like to mention that in a country with weak routine immunization program, the change of a dose formulation actually might be more of a burden than a solution. It is a very small aspect of what the routine immunization program is all about. When we talk about immunization systems, we talk about leadership and governance, we talk about the availability of adequate financing, the availability of vaccines and other inputs. We talk about health workers capacitated to be able to do what they need to do, quality of service delivery, quality of monitoring, and data systems. So here, probably the shift from 10-dose to 5-dose vials will probably only address issues related to vaccine availability as it relates to service delivery. But that has to happen in a very conscious manner, meaning that just the change of formulations will not give us the results we need. As various speakers mentioned, there has to be a very systematic change of health worker behavior to ensure that the vials are opened readily with 1 or 2 or 3 children at the vaccination post, improving the customer user experience, but also making sure that opportunities that would have led to missed children are closed as much as possible and utilized for improved vaccine delivery. Now, across the region, we have MCV1 coverage levels of somewhere around 70-71%. And I'm afraid over the last 20 years, we have literally leveled off at that coverage level, vacillating 1 or 2 percentage points up and down. And that, despite the fact that we are reaching more and more children every year because the birth cohort keeps growing, but there are deep fundamental structural challenges that have prevented us from going further, that have basically put a glass ceiling preventing us from improving our coverage further. So for many countries, we have been relegated to relying on mass campaigns, frequent mass campaigns, to be able to close the immunity gaps. But even then, I think knowing that routine immunization is the fundamental root program component that should be sustained as much as possible, I think what we're trying to do by shifting to 5-dose vials is bringing a little bit of a change there to make it easy for health workers to vaccinate children and reduce missed opportunities. And basically, that should mean within the current context where we have once a week or once every 2-week kind of measles vaccination should change into everyday measles vaccination sessions as much as possible. I think Maggie mentioned her experience in Addis Ababa, but if you go towards rural areas in any African country where the volume of vaccinees is very low for a daily vaccination session, what we see with measles is once every 2 weeks or even in some cases once every month vaccination sessions when health workers use 10-dose vials. So what we expect is those vaccination sessions will be more frequent, that it will be also linked to communication to parents and caregivers that they can get their vaccines whenever they present themselves to health facilities on any curative visit or any preventive health child visits. That is the kind of future that we're looking at. And for that to happen, something that has not happened systematically in the 15 or 16 countries that have introduced MCV 5-dose over the past few years, we need to set up a system where they document session frequency, particularly session frequency using 10-dose vials. They document session sizes. They document health worker behavior when it comes to how many children they wait for before opening a 10-dose vial. So those becoming the baseline, I think once countries shift towards smaller dose vials, 5-dose vials, it would create a perfect comparator for us to see whether there has been real change in terms of service utilization, which can, in the future, will pay off in terms of increased coverage and reduced missed opportunities, both for first dose as well as for second dose. And I think that has not happened systematically, and that is probably one area that we think we will need to push as more and more countries take up 5-dose vials. So this is just some points that I wanted to mention at this point. Back to you, Anthony. Thank you.
Thank you very much, Dr. Balcha. Okay, so it's now 7 minutes past, so maybe for 20 minutes or so, I'm going to hand you back to my co-moderators, Prof. Gulam and Maggie Archbold. There's a number of questions in the Q&A. There's also some other questions that we thought about. And maybe you can just take turns, Maggie and Gulam, to ask whichever panelist is most appropriate, or the whole panel, some interesting questions. And then around about 25 past, I will draw it together again. Over to you, Maggie.
Great, thank you. I want to highlight one of the questions that's in the chat, and this one's for our Ethiopian colleagues, and it relates to a question that I had as well. So Rebecca Kapota asked for clarification on the approach used in the Ethiopian study regarding household level delivery, and whether or not this refers to door-to-door vaccination. If yes, interested in understanding how they maintain quality during those sessions, including waste disposal, cold chain maintenance, etc. Building on that question, I wanted to directly reference Dr. Mulugeta's presentation, where he highlighted that whereas session frequency with the 5-dose switch increased at fixed sites, Dr. Mulugeta noted that outreach services declined, and that this trend might highlight important operational trade-offs for the switch. I'm curious to understand this dynamic better, and to better understand what the core drivers might be for the decline of outreach services, and to what extent you believe that's related to the vaccine presentation change, or there might be other potential factors.
Thank you, Maggie. For the first question about the household level data, apologies, we were given 5 minutes. I didn't know that I could use more than 5 minutes, and I tried to finish within 5 minutes. We tried to compare evidence from household level. That means interviewing mothers or caregivers, as well as recorded data at facility level. So when we say household level, it doesn't mean that the vaccination was provided at household level, like a campaign, but we had data from household level. We implemented questionnaire, and also we tried to refer the vaccination card. So that when we say household level, we mean about that, not about the service provision at household level. I hope that's clear. Regarding the outreach issue, this is not fully explained because we had that question, otherwise we didn't have a reason for that. So it could be a good research question for us to further explore the reason beyond the decline and outreach session. But I could say, before our study, there were multiple campaigns, big catch up services, maybe, and also that the season was maybe early second quarter of the fiscal year. So I'm not sure. I cannot mostly say that this was because of that, but I could say like one of the reasons was they had some recent campaigns. The other reason could be the services available at daily base for the MCV, but I don't think that MCV or the house to house or campaign-based vaccination is for MCV only. When they do for others as well. So this is, for me, roughly I can say this is could be resource related or other things, but this is not, as a researcher, I could say this is not fully explained, and we didn't address this, and it would be a good research question in the future. Maggie, apologies. I saw two more questions which are concerning Ethiopian findings. Shall I go and address?
Please go ahead. Or maybe if you could either do them very quickly or select one, and then so that Dr. Gulam might ask a question related to the Zambia study. But go ahead, Mulugeta, as appropriate.
All right. The importance regarding the caregiver knowledge was also asked. That was very important because, some of the mothers or caregivers could think that vaccination service is not there, or when they go and they go there and they may not find it. So it reduces a missed opportunity to vaccinate. That's one of the things. The other thing is vaccine confidence and also social trust. When they are aware, they could have more confidence and trust or satisfaction. And MCV completion, like they may think they may not get, like they may consider, like, for example, every Wednesday, I miss Wednesday and I don't have to go on Thursday. So it avoids such types of understanding or awareness problem. And also it could, if there is a problem of awareness, there could be issues with demand, confidence, and vaccine hesitancy. So for that sake, it is important. Regarding the criteria, somebody asked about the criteria of selection. We closely worked with the regional EPI coordinators or managers at the regional level, as well as the Federal Ministry of EPI team. They made it happen. It was because of their cooperation that we could succeed to complete in a short period of time. So the selection in terms of geography, distance, and other things, we try to have almost not exactly similar, but almost including other socio-demographic characteristics, almost nearly similar settings. So those are the points that I would like to address. Thank you so much, Mike.
Thank you very much. Over to you, Dr. Ghulam.
Thank you, Maggie. I think my question is for the wider panel, but probably to Mumbi to start with. That what preparation should be in place before the switch is undertaken, as Zambia has a longer experience post-switch? Thank you.
Thank you. Sorry, your question, I didn't get your question clearly. It was a bit of an echo. If I get you correct, you're asking what preparations need to be made before the switch?
Absolutely. Thank you.
Okay, thank you. So I think for Zambia, what was done was what we call as a silent switch. So the switch was done in and around or towards just the end of COVID. So we had a lot of restrictions in place around movements, gatherings, and so on and so forth to try and manage the COVID pandemic. So when the ministry was rolling out the COVID pandemic, there was no, how do I put it, like one big event where the switch was announced, launched, and then a guidance given that we've now stopped using the 10 dose for routine and switching to 5 dose. So it was a phased approach done over a course of about 6 months, where communication was done through the Ministry of Health channels, from national to province, district, all the way down to the facility issuing the instruction around the switch. But I think what is important to have in place is that it's important to communicate the information to the health facility staff. So provide the information on the switch, what's basically giving instructions on what they need to do to manage the use of the vials themselves at the facility level. And this is important because we still have the communication of using the 10 dose for campaigns, while the 5 dose should be strictly or should be used more for routine. So it's important to have that communication passed on to the healthcare facilities and the health facility staff, because you might end up having a situation where the 10 dose vials still filter back into the routine immunization as they try to manage issues around expiry dates and so on and so forth for the vaccines that they have in stock.
Thank you, Mumbi. May I just ask another question, actually, which follows on from your responses? That so in both Zambia and Ethiopia, communication disruptions has been reported. How that could be addressed or should be addressed moving forward?
Sorry, could you just repeat that? I think there's a bit of an echo. I'm having trouble getting your question.
Both studies reported communication disruptions during this switch. So moving forward, actually, how that could be addressed?
Right. So, yeah, I think it's important to have a structured way of how this information is disseminated. So, as opposed to how it was done in the case of our switch, I guess my thoughts would be that providing the necessary materials around the switch, beyond just informing them that there's this switch that is going on, but you actually provide the materials that guide on issues of management of the stock that they have, administration, and so on and so forth. Basically, providing all the necessary information that allows them to perform their functions even as they switch from using the 10-dose to the 5-dose vial. Yeah.
Thank you. Back to you, Tony.
Thanks, Maggie. Back to you.
Tony or any Nish colleagues, am I missing any questions from the chat? Otherwise, I'll ask another, but I want to make sure that I'm addressing questions from the audience.
Alana, Salim.
Elizabeth.
I think I think for some reason I'm not seeing them well, so perhaps Elizabeth or Alana can bring in some of those questions.
Maggie, they are in the Q&A. You will be able to read them from there.
Yeah, it's the Q&A, not the chat.
I see. Okay.
8 questions there.
Well, I'm going to take a minute to digest it. So if Alana wants to bring one in, please.
So Maggie, Salim has just displayed some of the questions, so you can read from the screen. Can you see them?
I can, thank you. The importance of caregiver knowledge about switching. So this seems like a question for both Mumbi and Mulugeta. And as a bit more context for this question, I also want to come back to Dr. Balcha's comment about vaccine trust and confidence in the service system. So when there's only once weekly vaccination sessions, which is more common in rural areas, as Dr. Balcha mentioned, shifting to daily sessions in itself, we hope, would increase community and drive community trust. So even that behavior shift at the health facility should have some impact on how the community accesses services. But I'm curious to hear from both Mumbi and Mulugeta what your thoughts are about the importance of caregiver knowledge about switching, and in addition to that, what kinds of strategies might be used to increase caregiver trust and access in vaccination services.
Thank you. I think for me, the importance of caregivers knowing about the switch is that I think the practice is usually from the healthcare side, that is. The practice when they have the 10-dose vial is that they will wait until they have, at least 7, 8 children before they can open the vial to try and prevent wastage. So where they have fewer numbers, they'll typically turn away the caregivers and ask them to come back at a later time, or ask them to wait until there's a certain number, which I think contributes to hesitancy for caregivers bringing children for vaccination. So having them know about the switch, informing them that there's now this change in the dose presentation. You don't need to wait until there's 7, 8 of you for you to be vaccinated. You can come 2 of you, or 1, 3, whatever number. Then the facility staff will be able to open the vial and vaccinate your children. I think that's important to communicate to the caregivers as well. And this might, to some extent, encourage them to visit the local health facilities for immunizations. Thank you.
Any comments, Dr. Mulugeta?
Yeah, thank you. In addition to the confidence, social trust, and also reduction in MOV, informing the caregivers or communicating the caregivers is very important, because they could face some anxiety about the product itself. So we need to inform them that the vaccine is the same and the vial is smaller. Like otherwise, they may think that, have they changed the vaccine? They used it to have in a weekly base or monthly base. Why they changed this? What type of product is coming? So it's very important to inform about the product, and also that only the vial is changed, not the quality of the vaccine. And also then even to address the issue of, like, they had experience of long waiting time, and also even lack of vaccination after they arrived to the facility. So in that regard, we have to inform them, or they have to be informed that they can get their kids vaccinated immediately without any waiting, because a small number of children is enough for that. So for that, we can use different types of approach, including health extension workers or community-based or local radios using local languages, and also even existing maternal and child health platform. That means antenatal care or delivery services could be used to simply inform the switch, and I would suggest having even consistent message in different languages, so that the mother could be aware and no misinformation or disinformation could circulate before we provide the right information. Over to you. Thank you.
Thank you. And I want to, there are a few trends in the chat. One, there's a question for Gavi, and I wonder if Amina might be able to address it directly in the chat so that everyone has that Gavi guidance. There are some questions about the declining coverage in Zambia and understanding better if there are some other confounding factors that might be influencing coverage. The downward trend had already begun before the switch period, so maybe COVID, maybe something else might be a reason for that. And there were a few questions also about cost. So, but I know that we have, what, 4 minutes. So yeah, Tony, how do you want to handle it?
No, that's fine. I want to give Gulam a chance to pose one more question. But maybe what I would suggest is that if any of the panelists do want to post some answers there, but also that the niche team is going to collate them, refer them to the relevant person, and hopefully get back to the participants with answers as well. Unfortunately, that's what time does to us. But Prof. Gulam, a last question from you, and then I'll wrap up.
Thank you, Tony. Mindful of time, briefly to both Mumbi and Prof. Mulugeta. So what is the evidence gap from both of your studies? Just one very brief comment from each. Thank you.
You get that, Dr. Mumbi?
Yes, I did. Yeah, the evidence comes from Zambia. I think one of the main challenges we had was with the costing data. So we had a lot of challenges. I think documentation and records management for not just the costing data, but overall remains a major challenge. And specifically for our costing data, we had data from 2024, which our costing team then annualized and used some backcasting approaches to try and adjust for inflation and estimate costs pre-switch, which is around 2021, to try and see what that would look like. So that also comes with a lot of assumptions, which may or may not be accurate, although they do give a good indication around changes as far as costing is concerned. So I think for us, the evidence gap is our data management, how we collect and record our data and use it to analyze and make decisions. Over.
Thanks, Dr. Mumbi. Dr. Mulugeta?
Yeah, thank you. Regarding our study, there were some challenges in terms of evidence gaps, like missing data from Gambela, for example, due to some conflict. We couldn't collect the underlying data, and also limited data from Somali region, because the launch of switch it happened very lately. I also agree with Mumbi regarding the absence of, in our case, because we had only 2 months data and we didn't have long-term data on posting. Overall, the post-switch observation window was very short. So we didn't have also no like societal cost dimension was not addressed, and the problem of seasonal variation could cause like we included short term, and that means we didn't have Ethiopia has 4 different seasons, for example. We didn't address those things, so maybe we recommend further continuation of such type of research to have good evidence for others, and to check even for the seasonal or other confounders. Thank you. I also mentioned about the decline in the outreach service, which is not fully explained. Thank you. Over to you.
Thanks so much, Prof. We have come to the end of the session. It's exactly past. All good things come to an end. But I'd just like to really thank our panelists, Mulugeta, Mumbi, Elizabeth, Balcha, and Amina, and also my co-moderators, Maggie and Gulam. I think we all face having to change, and it's never comfortable. But the strength of a webinar like this and getting together is that we can share experiences and learn from each other. And hopefully this session has been something of that. We've heard from researchers, we've heard from the WHO, we've heard from Gavi, and we've heard from yourselves. And so my last thank you is to all the participants online. Thank you to those who posted questions. It's, I think, been a really good discussion. So thank you from me. Wherever you are, whether it's morning, evening, or afternoon, be safe, and thank you for attending. Goodbye.
Thank you.
Thank you. Bye.